So I'd now like to introduce our first speaker, Dr. Mitchell Sabloff, who will give an overview of AA and PNH. And then after the break, he's also going to speak about MDS. So Dr. Sabloff is the head of the Ottawa Hospital Leukemia Program and the co-director of the Ottawa Hospital Hematology Biobank. He's an associate professor of medicine at the University of Ottawa, a member of the Blood and Marrow Transplant Program at the Ottawa Hospital, and a clinical investigator at the Ottawa Hospital Research Institute. His research is focused on studying patients with refractory acute myeloid leukemia through clinical trials, translational studies, and work with several cooperative groups. Locally, Dr. Sabloff, in collaboration with scientists at the Ottawa Hospital Research Institute, has helped to uncover mechanisms of and potential therapies for refractory acute myeloid leukemia. And their team continues to develop these studies supported by funding from the Ottawa Institute for Cancer Research, the Canadian Institutes of Health Research, and the Department of Medicine of the Ottawa Hospital. So welcome, Dr. Sabloff. Thank you.
So welcome. Thank you for the introduction. Thanks to CBS and everyone sponsoring and and for people who've come. It's always always a pleasure to be able to share what we think we know, hear feedback from you guys about what your impressions are about either how we're delivering care and how we can do it better. And sometimes this is a good way of outside of the clinic we have more time now to chat about stuff so that the clinic gets fast and not everything gets answered the way in a satisfying a way. So it's good to have these opportunities to share and talk a bit outside of the busyness of the hospital. So how do I? So and I think I think we thought there was 3 speakers, but then it turns out there was only 2 of us. So you have to, unfortunately, you have to hear me twice. So hopefully that is not a bad thing, but we'll see. Anyway, so the first thing I'm talking about is aplastic anemia and PNH. So I don't know how anybody on. I don't know if everyone has. Most people usually have MDS, but so I don't know how many people have aplastic anemia or PNH. But we'll talk about that first, and then the next after the break we'll talk about MDS.
I just have a comment that you're a bit hard to hear.
I'm hard to hear already.
Can we move the mic closer?
Where's the mic?
It's in that as well.
So I turn it on here.
Sure, we can switch.
That's just maybe that's better. Better.
Yeah.
Okay. Unmute.
Will it help to move that?
If I talk to
You turn your speakers off. There we go.
Okay.
So we're gonna have to use this one, unfortunately. But maybe if you could speak up just a little bit.
Okay, is that better if I speak louder? Is that better? Any thumbs up or yes? No? Okay. Well, Oh, well, if so yeah, so I'll try to speak louder and then let me know if there's, let us know if you still can't hear, no point in doing it, if you can't hear me. Okay, so, this again. Okay, so. Okay, right, so, so this is the, so start with this, just the hematopoietic system, so I think you can, oop, you can't see my mouse. I'm not using, not my mouse, oh, it is my mouse. This, this one. Oh, anyways, so at the top is the pluripotent cell, which divides into two lineages, the lymphoid and the myeloid. The myeloid one is the one that we're mostly concerned with in these diseases. So myeloid, as you can see at the bottom, they make all the cells that you're familiar with, the white cells, the red cells, the platelets, and the disorder is usually way at the top, at the myeloid stem cell area, where uh, where which is affecting all the, that if that cell is disturbed, then none of the other cells are being affected. And you'll talk about how that cell gets affected. This is just a picture of the bone marrow. So on the right, on the left is a normal bone marrow with a lot of cells. So you can see the purple, the pink, solid pink is pieces of bone, and in between that are the spaces where the cells are being made. So all those little dots are little cells with little fat droplets in between. And on the right is a bone marrow, which has, as you can see, very few dots in between the pieces of bone, which is sort of exemplary of aplastic anemia, where there's hardly any cells to see. So was that clear? But this is a good example. And so BMF, bone marrow failure syndrome. So when we talk about aplastic anemia, most of the aplastic anemia that we are familiar with is we call idiopathic, or we don't know exactly why. We presume and we treat it like it's an immune attack on that upper part of the hematopoietic system. But whenever we see people with low blood and aplastic anemia looking bone marrow like that, you have to rule out a lot of other reasons for the marrow not functioning before coming to the more common diagnosis of just idiopathic aplastic anemia. So there are other causes that we look for when we meet people, when we do blood work, whether it's possible toxins or drugs, or and the drugs are usually chemotherapies, or that's certainly common these days, where people are being treated for other cancers, and that can certainly affect their bone marrows. Infections can cause the bone marrow to look quite empty, PNH, which we'll talk about later in this talk. And then there are some inherited ones, where usually those are found in younger people, and that requires some genetic analysis. And then there's this overlap with something called myelodysplastic hypoplastic myelodysplasia. So there's a long list of possible other causes of having an empty bone marrow, which we have to go through. And so here's just a little bit of a schematic of when we look at sort of inherited and acquired. So acquired is the one that we are most familiar with, and is the one that gets the most attention, especially in the adult world. The inherited one is usually younger people. And they might have a positive, there might be a family history of low blood counts, and so these are just some other criteria or clues as to if this is likely to be an inherited or acquired aplastic anemia. And there are different, and there, like I was talking about, there are different laboratory tests that can help us. So there are the usual regular blood tests that we look at for that you're familiar with, like the CBC, and looking at the kidneys and the liver, and then there are other special tests, some that are looking for these inherited bone marrow failure syndromes. So there's a disease called Fanconi's anemia, which is which is a test called the chromosome fragility. There's a test that looks at the telomeres. So telomeres are the ends of chromosomes, and they tend to get shorter with age, but in some cases they are quite short very prematurely, and that signifies another type of disease. And so, anyways, there's a series of tests, like I was talking about, that to rule out the some rarer and importantly other causes of bone marrow failure or aplastic anemia, because they would be treated differently. But the aplastic anemia, either idiopathic or acquired, like that we're most familiar with, is still quite rare, 2 to 3 cases per million. It does occur in younger people and older people, and like I said, it's understood to be an immune attack on the hematopoietic system, on those stem cells at the top of the cascade, and so that whole cascade is blocked. What's good is that those cells, they're not damaged, so there's very few cells. It looks like there's no cells in the bone marrow. Stem cells make up a small minority of the bone marrow, so you don't need a lot of them there, but you need some. And so they're not damaged typically. And then there's some patients may have these PNH cells, and that depending on how many and the way the scenario, anyways, again, the treatment might be a bit different, or has different significance. It's certainly on how we might treat. And a typical case of someone with aplastic anemia might be like this 39-year-old woman who presented with fatigue and some nose bleeding for the past 2 or 3 weeks. Her white count is, I think, for people who have the disease and are familiar with the numbers, white count is 2.4, so that's on the low side. Normally it should be 4 to 10. The hemoglobin is 55. Again, that should be 120 to about 150. The platelets are less than 5. That's very low, very low. Anytime the machine says less than whatever it is, that's the machine can't go any lower, and pretty low. Neutrophils 0.2, and again, those are very low. The lymphocytes are 1.8, and so when you break down in that white count, when you break down the 2 main cells in the differential of white cells are neutrophils. So, and I think people are familiar with these numbers if you've had the disease and you're following your numbers, which a lot of people are doing. And if something's not, certainly stop me if something's not familiar or I'm talking about something that seems unclear, then just stop me and we'll clarify it. But typically, yeah.
Do you have those kind of specific numbers in the pamphlet or anything? I'm not good at following this.
I don't know what's in the pamphlet, but in the what's supposed to be normal, you mean?
Yeah.
Oh, well, I don't know if they're normal, but I mean, I could certainly give you an idea of what's normal. But but these are, yeah, so everything's low except the lymphocyte count, which is typically in aplastic anemia, it's preserved. So because they live a long time, and the reticulocyte count, which is immature red cells, is also very low. So that number should be, normally it should be somewhere 60 to 80. If your hemoglobin is 55 for a few weeks, that reticulocyte count should be 200, 300, 400 if you have a normal functioning bone marrow. So 27 is really low. And in this case, she has a small PNH clone, which is not so rare in people who have aplastic anemia. And then LFTs are the liver numbers. The ANA is autoimmune antibodies, which is, again, it's low. That's supposed to be low. That's sort of normalish. That's not an uncommon finding. ANA goes along with autoimmune diseases like lupus or rheumatoid arthritis or other rheumatologic or autoimmune diseases. And again, you need to rule out these other diseases before assuming this is just an acquired aplastic anemia, right? So if it's aplastic anemia that's secondary to another disease, that you need to treat that other disease. And so we do look for other diseases. And so the aplastic anemia that we are talking about here is one that we have to rule out all the other causes before we treat this one. And again, chest X-ray, CT scans are important because, again, looking for other diseases that might cause the marrow to fail, doing a bone marrow, and then there's and then treatment. And in aplastic anemia, we do a bone marrow like we saw earlier. Bone marrow is helpful in giving us an idea, again, if this is true aplastic anemia or if it's just a little lower than it's supposed to be. So certainly if it's hypocellular, less than 25% of the bone marrow has cells. So normally the bone marrow, if you remember in the initial slide, there was a lot of little dots. There were all those cells, and there's some spaces in there which are fat globules, and it should be about 50-50. So that on that left hand picture, it was about 50-50 of cells and space. So, but when you get down to less than 25%, that's clearly abnormal. It does get less as we age. So a young person may be up to 60 or 70%. An older person may be 30 to 40%. And then ultimately it depends on what the blood looks like. So to match that. So I always remind people that bone marrow is a tiny little piece of your whole functioning bone marrow. So it can vary a little bit, but in any event, it's less than 25% is kind of a clue. And then the severity of the aplastic anemia depends on the blood. So that neutrophil count is really key to deciding whether this is we call it. So there's severe aplastic anemia where the neutrophil count is less than 0.5. And then the category below that is very severe aplastic anemia, where the neutrophil count is less than 0.2. And then everything else we call non-severe. There's sort of severe, not very severe. And the reason for that is that the risk of having serious infections is quite high when you get a neutrophil count below 0.5. So 0.5 and 0.2 are kind of those often, and a lot of people with whether it's MDS or low blood counts for whatever reason, but the numbers are, the neutrophil count may be, the normal is above 2, but sometimes it's 1.2, and the machine flags it as being low, and so people get nervous about their neutrals being too low. But from a real practical point of view, less than 0.5 worries us as hematologists. Everything above that is less worrisome. And so sometimes we seem less concerned about the disease than you, but that's because of some of these clues that we have of, is this, how worried should we be, and how quickly do we need to act to try and fix these problems? And so certainly the severe and very severe are the ones that we act on more quickly, and the non-severe ones are the ones that we can take some time, if needed, to do more investigations and see, and some of those will actually resolve on their own, especially in younger people. So it's good to spend some time, sometimes doing not too much, to see if the disease goes away by itself. And like in the case, so signs and symptoms, people present with fevers, or they may present with bleeding or fatigue or being pale. And then that's the classification again. Mechanisms. So one of them is this, like I was talking about, these telomeres. So there's different mechanisms, and the shortening of the telomeres seems to be maybe part of it, but both in a hereditary way and maybe in the typical aplastic anemia. And so, that's sort of going through what it is and how we diagnose it. And then, so treating is, because everyone wants to know how to treat it. And so, like I was saying, the first thing is to rule out other things. So there's no, some diseases have a diagnostic test. This is the test to diagnose this disease. In aplastic anemia is kind of a differential. So you see the bone marrow empty, and then it's, this is the list of things that can make the bone marrow empty. And so we need to rule out all the other things. And if we don't have another cause, then it's this acquired typical aplastic anemia, which makes up about 50% of everybody who has an empty bone marrow. And then the choice of treatment is kind of, there's two main approaches. One is a transplant, and one is immune suppression. And how do we decide? And so the non-severe, like I was alluding to or talking about before, like I said, they may not need any therapy. So depending on the scenario, depending on, does the person require transfusions, or what's the risk of infection or bleeding? So all these things go into deciding whether we need to actually treat the disease. So the symptoms. So the picture in the bone marrow is one thing, but then the symptoms of the person in front of you is really determines a lot of how you might approach the disease. So do they need transfusion of blood or platelets? Is it associated with another disease like MDS or PNH? And are there other things that can fix it? So are the vitamins, so folic acid and B12 are crucial to the functioning of the bone marrow. So if there's some easy things that can be fixed sometimes to allow the bone marrow to function better. Whether this is, sometimes people have a viral illness just before, and so that may take a few months for that to resolve, and then, or medications again, that may take some time for the marrow to start functioning again. So, but if none of those things, if the person's symptomatic, needs transfusions, there's no other reversible cause, then we need to think about a therapy. And the therapy is a form of immune suppression. And we balance that with transplant, and you'll see why, or how we decide. We'll talk about the different, or what's involved in immune suppression. So The severe and very severe types of aplastic anemia always require therapy. They usually don't resolve on their own, and they're usually quite symptomatic. And like I said, you want to, the risk there is of infections, and you want to try and treat them before they're going to have an infection, because that can be the most detrimental, or the lead to the most detrimental effects of the disease. You want to minimize exacerbating factors, and we look for, again, other disorders. PNH and MDS are important in terms of deciding on the therapy. Having a PNH clone, so we'll talk about PNH soon, but having a PNH clone with aplastic anemia is usually a good thing. They usually respond well to the therapy, and so that's not a bad thing. But having myelodysplastic syndrome with it can be a bit more of a challenging scenario. And again, in the therapy, then again, we're deciding whether between a transplant and immune suppression. So treatment, again, so transfusion support. So usual kind of support is important. Any therapy that we give is not going to be very helpful if you're not, putting in the fuel or trying to avoid problems, making sure that again, vitamins are topped up. And I only stress that just because you can't have too much folic acid or B12, but if you don't have enough, your bone marrow is not going to work well. And then there are other causes. Some people can have hemolysis, where on top of the bone marrow not working properly, there's an immune attack of the cells that are being made, and so that's not very helpful either. This is a little bit of skipping over with PNH, but some people can have blood clotting with the marrow failure. So, but in any event, and so the history is that we initially there was if people are familiar with different kinds of immune suppression, so prednisone or steroids are usually thought of as immune suppressing medication, and they are, but they don't work very well in this form of immune attack on the cells. So but then cyclosporin, which is a drug that has been used with organ transplant and stuff, does suppress another part of the immune system. So there's, see, the immune system is a complicated area of many different sort of facets to it. So cyclosporin was used and was helpful at controlling the disease in some people. And then this other agent called ATG, or antithymocyte globulin, was added. It's a anti immune therapy that's made in other animals. So it's where they take human lymphocytes and put them into another animal, and so the other species will make antibodies to that tissue, and then they take those antibodies and then they inject them into the human. And so typically they're made in horses or mice, not rabbits, rabbits. And then I saw some other papers where they're made in pigs, but I don't know why. All our history is using them in horses or rabbits, and when you hear about ATG, if you've ever come across, or it's some terms like this, we use the same term, but they do different things. So if it's ATG from a horse, it has different properties than if it's ATG from a rabbit. So some are more immunosuppressive than others, and so and so you'll see that which one works better. But so so you can see when we did cyclosporin works, but cyclosporin with ATG has less failure, and then but the overall survival seems to be the same. So we manage, as long as we use some immune suppression to block the T cells, they seem to work well. And then there was a more recent, it's not so recent now, but it's where we compared, it was compared the horse ATG and rabbit ATG, and horse ATG comes out as being better to start with, anyways, as a first line therapy. So horse ATG is usually the one that we use best. So you can see on the left that there's the survival is better with horse. Well, there's similar outcomes. One is where the data was, if you had a transplant, you were taken out of the analysis. And then the new kid on the block is a drug called L-trombopag, which is a group of agents that help to move the growth of platelets, but that's where it started, and it's used a lot in a disease called ITP, or idiopathic thrombocytopenia, where all the other blood counts are fine except for the platelet count, but it does seem to have a broader impact on the hematopoietic system. And so what they showed was when you add L-trombopag to the cyclosporin ATG, there was a faster recovery of the blood counts. So there was faster recovery of blood counts, and more people stayed in remission when you had the triple therapy. We can't always get L-trombopag when we start, but we'll see how that changes. So here you can see that if you had the L-trombopag, the median time to your first response, and I think this is important too, also to highlight when we treat aplastic anemia, that it's a slow, when the treatment works, it's not something that works like in a day or a week. It's over months. And so you can see that the first time to response without it was 8.8 versus 3 months. The platelet transfusion independence took 68 or 40 days. Slow, the shorter was with the L-trombopag, and red cell transfusion independence took up to 51 days with L-trombopag added, and 140 days. This is sort of median times. And the response depends on age and disease severity, and the addition of L-trombopag. Overall survival is still high, which is good. And the relapse rate at about 18 months was lower with L-trombopag. But the excuse me. So transplant in the disease is to replace the blood cells, and used when you have hereditary causes of aplastic anemia. You need a donor, and as you can see, but the survival gets worse as you get older, and older isn't very old. So over 40, so 20 or less than 20 years old, or 20 to 40 years old, they do pretty well. As you get older to over 40, then the rate of success with transplant gets lower due to some of the toxicity of transplant. And so studies like this show that and that's why 40 seems to is sort of this magic number, that if you're under 40, then we try and get you to transplant if we can. But if you're over 40, immune suppression works slower, but more reproducibly, and has more success because of less toxicity. And I think that's it for aplastic anemia. I don't know if anybody has any questions. Yeah.
No.
No? No, that was just,
I have.
Yeah.
That's what I have.
oh, yes, okay. So, so sounds familiar or, yes?
Yeah.
Sorry,
I have one question. Were you saying it's sometimes hard to access El Chompatay?
yes,
Is that provincial funding or?
yes,
Okay,
yes, always provincial funding, so.
yeah,
Sometimes we can access it through private insurance upfront. And if we can't, then often we can get it not at the beginning, but shortly after starting. So is that me being there all the time? Maybe. No, sorry. So P&H, I don't know if anybody has P&H, but we will go through it. And it's somewhat similar, but have become much more complicated. So this is a slide that the last time I presented this is the slide I ended on. And I thought I would start with it because it's a disease that has had sort of mostly one therapy for a long time. And I ended it saying, well, there's all these other therapies that are in development, and it's even more rare than aplastic anemia. And I wasn't sure how or why so many therapies would survive in kind of in that space. Sorry, that's my family making a lot. So if I'm beeping, I'm sorry. And so, but now in the past few years, there's been a number of therapies that have been approved to add to the treatment. So it is again rare, one per million per year. We have about 5 or 6 in patients with PNH, with just PNH in Ottawa. There's many more people that have a clone but don't have the disease. The median age is about 40, survival 10 to 15 years. It's certainly better now. It's so rare. It is, and we'll talk about this a little bit. This uncontrolled activation of complement activity, and complement is part of this complex immune system that we have, and it causes hemolysis, which we mentioned earlier, which is this attack on the red cells in the blood. So any blood that's being made is being broken down in the blood, and it can affect the red cells and the white cells and the platelets. And the picture on the right is urine from the classic way that people presented with this was that they peed kind of black in the morning, particularly. That's not how people usually present these days, but anyways, that's the history of these diseases is kind of always fascinating and always important to help us understand where we came from a bit and why we are doing what we do. So, like I said, so hemolytic anemia, or this breakdown of red cells, is important in the disease, but it also can cause bone marrow failure. So I was talking about that before, where you can have aplastic anemia with a PNH clone, and importantly also it can cause blood clotting or thrombosis, which is one of the main causes of morbidity and mortality in PNH. This is a bit of history which we can skip through a little bit time. To get to the real crux of what we now know about this disease. So we've known this for a while, that that the problem in this is that these cells have a defect in this gene, which is PIG-A. What ends up happening is, so you can see down the bottom there that's a part of the outside of a cell, the lipid bilayer, the cell outside of the cell, and proteins that are inside or outside the cell are anchored into the membrane with different links. so this one linker is called GPI, or glossar, these GPI anchors, and mutations in this gene will disrupt that anchor. And so there's a lot of proteins that are linked this way and will be absent on the red cell because of this linking, this anchor isn't there. And two of these proteins are related to, this is a little prettier picture too, but two of the proteins are, so you can see that on the left picture there, it's a normal red cell, on the right it's a PNH red cell. And so those two proteins, CD55, CD59, are some of the proteins that are not linked to these red cells. And those proteins are important in protecting the red cells from this part of the immune system called the complement cascade. It is, I think it's here. Yeah. So this complement cascade is this series of steps that goes through there. It starts. There's different things that can activate it. It's quite active usually, and it's to try and destroy foreign invading cells or microbes or different things. But our cells are protected by these proteins that are usually anchored to the red cell, the CD55 and CD59. When they're not there, then our cells are also susceptible to this attack, and so they can be destroyed by our own immune system. And so that's another little picture of these holes that we picture when they're not there. When this part of the immune system is working, it causes these holes in cells, and causing holes in cells is not a good thing. The membrane around a cell is there to keep things out of the cell and keep things in the cell. So when that is bypassed, the cells are very unhappy and don't live very long. So again, it's on that uncontrolled complement activation, which is key to the disease. The mutation, though, is not sufficient. So we know this because there's a lot of people that have a small clone of PNH cells, and although we call them a clone, and when we talk about clones, that usually is like cancer, but so PNH is not like a cancer in that it doesn't invade by itself. The cells are there. So a lot of us have small clones. Some are measurable, some are not. But it needs an opportunity. It's sort of more opportunistic. And so we, like it says there, autoimmune attack, something that has to cause the bone marrow to make space. And then when there's space, sometimes, so what happens is there may be an attack on the bone marrow cells, and the PNH cells may be protected because they don't have some of these proteins that may be attacked because they're missing the link that links these proteins to the membrane. So they may not be quite as susceptible to normal cells. So the normal cells may be attacked, they go away, and then the PNH cells are able to grow when the normal cells are kind of interfered with or inhibited. And like I said, they classically, there's this hemolysis and thromboembolic phenomena, blood clotting and bone marrow failure that can happen. There's this acronym CATCH, which is to try and help us to remember or pick out patients who may have PNH. So in the right setting, but certainly any patients that have low blood counts, have aplastic anemia, myelodysplasia, thrombosis for weird reasons, Coombs negative hemolysis. So hemolysis is a breakdown of the red cells, but and usually when that happens, it's you can detect it's Coombs positive, but typically PNH is Coombs negative. So that's again some of these blood test clues that we're looking for when we see low blood counts or bone marrow failure, and hemoglobinuria is just this hemoglobin in the urine causing the dark urine. One of the mechanisms that seems to be central to this is nitric oxide. So nitric oxide is a is a chemical that helps to, like muscles and things, relax for reasons of how the disease evolves. Nitric oxide can be mopped up and be quite low, and then that causes some of the symptoms that might occur. So some people can get muscle aches, and some blood vessels can contract, and so and as a common or something that's maybe more familiar these days, Viagra, which is quite commonly used, is and people are familiar with, is trying to release nitric oxide. So it's doing the opposite to what this is. It's not a treatment for PNH, but it's treatment for other things. So there's a lot to learn. We're still learning a lot about how PNH operates. The testing used to be quite complicated, or quite was a bit less clear, but now we use something called flow cytometry, which is a typical test that we use to diagnose all kinds of blood disorders, and it's looking for usually it's looking for those proteins on the cell, but in this case it's looking for the absence of that CD55 and CD59. And then there's we divide PNH into three main categories. So there's the classical PNH, where you have hemolysis and big clone usually, and but it can be, like I was talking about before, you can have PNH with bone marrow failure, like aplastic anemia or myelodysplastic syndrome. And then there are this other group of subclinical PNH where you can have a clone but no symptoms associated with it. And so these are different approaches. So the treatment has evolved. Like I said, it was I started my career with steroids, androgens, quite non-specific kind of treatment, and then this drug called eculizumab, which has been the treatment of the main treatment for the past decade at least. And if you have bone marrow failure, then we get back to how to treat aplastic anemia. So eculizumab has been the main treatment. It's an antibody that targets the CD5. So CD5 is, again, going back to this picture, CD5's at the end of this, or you can see CD5 at the top there, sort of the last main factor before attacking the cells. And so blocking that seems to be key to preventing the cell breakdown, because a lot of patients will be transfusion dependent, and blocking that may allow the cells to live longer, not be broken down. So reduces hemolysis and reduces the clotting problems. There are some side effects to it. A lot of people have some headaches, but usually we can manage that. And the therapy is every 2 weeks forever. So and then this is just a couple of the main studies that put eculizumab on the map and became the main therapy. This is just a couple of graphs that look at the dramatic change that these new therapies have made in the disease. So this is so there's some markers. The LD is a marker that is very high in PNH, and as you can see on the top, people who didn't get eculizumab, their level of LD stayed high, but when you started eculizumab, that level dropped to close to normal quite quickly. And the need to first transfusion was delayed a lot by eculizumab, and most important, and fatigue was better, although some people are still tired. But the main problem that people had, or main life-threatening, life-altering problem has been blood clotting, because blood clotting can be in different places. It was about 40%. It significantly reduced by people who are treated with these antibodies, and you can see, and then the survival is on eculizumab. So the one on the left is people who on eculizumab, the survival on eculizumab versus before eculizumab was used, and then when they and so that certainly made a big difference. Now, like I said, in the past few years, the treatment of the disease, the approach of the disease has become a lot more complicated because eculizumab isn't the main one. It's the whole a handful of other therapies now have become approved for different situations. Revoluzumab is like eculizumab. It works in the same way, but instead of needing an infusion every 2 weeks, you need it every 8 weeks. So that's hopefully an improvement, but you're still IV. Crovalimab is a newer version of the same group, blocking that last part of the pathway, but it's given subcutaneously every 4 weeks. So all of these have pros and cons a little bit and may suit different situations, maybe just in the way it's administered, but also in the way or directing the proper therapy. So so this way you don't have to go out to have an infusion, an intravenous infusion. It can be done at home, but it's every 4 weeks. Pegcetacoplan is now blocking C3. So C3 is further up. Go back to the pathway. So C3 is earlier in the pathway. We're in the middle there. So before C5. So there is some. So we have found that when you block C5, that works in most people, but not everybody becomes transfusion independent. So some people still require transfusions, and some people still have quite a bit of hemolysis, and blocking it at a higher level in the pathway seems to help. Sometimes they need to be done in combination, but so that has helped in some people where they have had, again, ongoing hemolysis that is not well controlled by the C5 inhibitors that were on the left of the slide. And then there's two other ones that block either something called factor B, which is another part of the pathway, or factor D. So that one. That's factor B. So you can see it's given. So these two are oral. One's given twice a day. One's given 3 times a day, and the pegcetacoplan is twice a week, but subcutaneously. So so they have different indications. Some are added, like the danicopan is added to a C5 inhibitor, and then I guess, and then sometimes it's the frequency that they're given or that they're oral, but you can't really miss doses because you need constant kind of control of this pathway, and so so oral is usually good, but I mean, I take medication sometimes once a day or twice a day, and sometimes I forget to take my second dose, but if you have this disease and you forget to take your second dose, that might be a problem. So sometimes it's better if we're giving it to the person, they have to show up. And it's, longer, longer duration sometimes. So there, I think that there's still a lot of work to do in optimizing the therapies and then also probably in some of the administration to make it easier. So, we know that there's always people have issues, whether it's multiple doses a day versus once a day. Some not here, but some drugs are weekly, but I don't know. I think if weekly, I would also forget to take. So in any event, it's this is another way of looking at the grouping. So there's those C5 ones, which are the protein at the end of the pathway, which are important, and then there are the C3 inhibitor, which is earlier and which is again can be used without the C5, so you can switch to that one. And then there's the factor D and factor B, which are more additive, but serve certain particular situations. So they're so and even if you switch to say a C3 inhibitor, in certain situations you need to access the C5 inhibitors for sometimes acute situations where the person may be destabilized. So it's that like it these are treatments that are not, they're not fixing the disease, they're fixing the problems from the disease. And so the problem or the problem is there, and it's an ongoing problem. And so that's why I said, like, if you miss a dose, you have to try and catch up on the doses before the disease starts to cause the symptoms again. And then I can finish with the same picture that there's a lot going on in the background in this disease, and it will become more and more complicated, I think, as we learn more about how to control the pathway and to protect ourselves from ourselves a little bit. And hopefully the treatments will become easier. So this is good. They have become easier from, I mean, I have a young lady who I've known for over 10 years who's been on eculizumab. So I think I met her when she was 19 or 20. So imagine a 19 or 20-year-old, and she has to go to an infusion center every 2 weeks to get her infusion. It has been a challenge sometimes when she was younger to make sure that she showed up. Now she's on revolutimab, and it's much more tolerable to have to just go every 8 weeks. Right? She's working, she's in school, and so these, the different pros and cons, the way they're administered can certainly have impacts on how successful the treatment might be. And I think that, yeah. So this is supposed to be after I thought I moved it. Anyways, this is just a way of summarizing it back to aplastic anemia, sort of the different steps of thinking about, eventually, should I treat this? Does this person need treatment, and do they need immunosuppression, or do they need a transplant?
We're going to continue with Dr. Sabloff talking about MDS now.
Okay. I'm not sure if I should talk in a different voice or, but probably best to stick to the one I have. All right. So, welcome back for part 2. So MDS. So this is a little bit more common than the last presentation. So I usually presume most people in the room or online are more familiar with this. So this is so we'll talk about a little bit about the epidemiology, the classification, treatment, new agents. Ascertain is a recent trial that we'll talk about that has made a big impact on some of the administration or treatment, and so and then I came across this. I don't know if you guys are more aware, but that October 25th was MDS World Awareness Day. So we're a little only a few days or a few weeks later, but probably worth mentioning anyways because we didn't get to celebrate it, or I didn't get to celebrate on the day, anyways. So a little bit about MDS. So it's a little different than aplastic anemia in that it is so the bone marrow is not empty. So the blood is low, but the bone marrow is not empty. It's actually the bone marrow is quite full of cells. They're just not normally growing, normally maturing cells. So this is summarized in this first statement about that it's a complex and heterogeneous group of clonal myeloid neoplasms. So it's all clonal, clonal, like I was referring to before, is suggesting that it's originating from one abnormal cell has started to make a bunch of itself and take over the space. And so, and then it's characterized by this ineffective hematopoiesis, which means that there's a lot of cells being made. They're just not like red cells are supposed to last 3 months, and they're not. So they're not doing that. And so the sometimes I describe it like if you're a car manufacturing plant, and when the plant is new, the cars come out and they're all shiny, and but then with time, if there's no maintenance on the plant, then something will retire. There's some rusty parts or things until the cars last less and less long, and so it's a little bit like that. That there's some aging and some the bone marrow is getting a bit rusty. I don't know, but in any event, the cells that are coming out of the manufacturing plant are not as healthy or robust as they once were. So they don't live as long, and that results in the low blood counts. And then there's this risk of progression to acute leukemia, which we are trying to avoid if we can, or delay. And so it results in low anemia, low red cells, neutropenia, low white neutrophils, white cells, and thrombocytopenia, low platelets. There's the risk of leukemia transformation. There's this overall survival of at 5 years of 37%. It's a little bit that doesn't sound so good. It's you'll see there's a better way of looking at the overall survival because we can classify people better, and so that helps to put people in, give you an idea of where you might fit on that scale. So there's some people who have quite short survivals. Most people are in the longer survival group. So again, it's also a rare disease, but more common than aplastic anemia and PNH, and that's just a racial distribution. So it's more common in the white population than the Asian Pacific population, the Black population, Hispanic population. I'm not sure we know why, but that's just an observation. In Canada, there's about 10 to 40,000 people over the age of 65 who've been diagnosed. The incidence is about 75 to 160 per 100,000. and that we diagnose. So we think that there's somewhere between 18 and 6,000 new cases of MDS diagnosed in Canada per year. So it's part of the reason that the range seems to be wide, and we aren't so sure more exactly what that is that it's certainly a disease in older people. There's a lot of people that have have some anemia, but may never get the investigations, right? So some people are, for a variety of reasons. So it's a nursing home. The anemia is not their main problem, or maybe it's assumed that it's due to something else. So we think it's probably more common than is sort of estimated, because there's probably a lot of patients that are not patients, but there are people that are not diagnosed with MDS who have it. This is again a graphic about the same thing, that you can see that it certainly becomes much more common in your 70s and 80s. And the older group there may be more common, but it's just not always diagnosed, because it's again maybe not the most important thing to get diagnosed at that time. And that goes into sort of talking to a little bit about that it's probably underdiagnosed, and so those risks are, or the number of patients with the disease is probably higher than we anticipate. There are some risk factors that are rare, high dose, being exposed to high radiation, some other blood disorders that can lead to MDS, some genetic risk factors, workplace exposures, which are usually minimized these days, and smoking, and generally it's not good to smoke. Has a lot of other health implications too. So I think when we talk about MDS, those are people who have had it for a while, people who are recently diagnosed, that may, there are limited therapies that have become available, or that have changed the landscape over the years. Although we hope that's going to be changing more rapidly in the near future. But one of the things that has helped both to try and identify therapies, but I think also provide better information to patients and families, is just the classification, so that's on the one hand it's good, on the other hand it can be quite confusing to patients and families about, they're talking about this risk group and that risk group, but they're using this classification or that classification, and this year it was this one, and next year it's that one. So it's all to help to understand the disease, both from our point of view and from your point of view better. And this is just a timeline of different classifications that have happened over the years. You can see there's a bunch that have, since 2020, there's a bunch that have populated that, and that's why we talk about, and some of them are a little not in disagreement, but classify the disease slightly differently. And the three that are most relevant, that we have used over. So if you've had the disease for the past decade, you're kind of span the three of them. So the IPSS, the International Prognostic Scoring System, was sort of a big change or move forward in terms of classifying. We don't use that one very much anymore, because it was replaced by the revised International Prognostic Scoring System, which is a bit more specific. And then now, more recently, is the Molecular International Prognostic Scoring System, which, as we learn more and we understand more about the mutations and we can measure them, we can be a bit more granular or specific about divide up the groups of people, patients with this disease, into more specific prognostic groups, trying to predict the future as best we can. But I think so just to show the difference, so the first one there, the IPSS, the International Prognostic Scoring System, basically was 3 groups. It was the bone marrow, the blasts, and again, if people aren't familiar with what I'm talking about, but usually these are familiar terms if you've had the disease. The blasts in the bone marrow, the karyotype, the genetic, the chromosome changes, and the number of cells that are low. The revised one now, it also uses the bone marrow blasts and the genetic changes, but then instead of just the number of cell counts that are low, it's they've broken it down into, is the hemoglobin below this level, is the platelets below this level, are the neutrophils below this level. So again, it's dividing the groups up into smaller groups, and you'll see how that translates. And then the more recent one now is this Molecular International Prognostic Scoring System. So we do the molecular testing, more detailed molecular testing on most patients. And so there's clinical data about the hemoglobin, the platelets, and the neutrophils. There's the genetic chromosome data, that's cytogenetics. On the left there, you can see there's the pull down. They break down into different groups, and then the molecular, which is a whole list of different genetic changes that again have different impacts on trying to predict the future. And when we put that all together, there's this a graph of where it's broken down into, on the left is very low in moderate low, moderate high, and very high. So, and it just shows you how many people, patients, sort of compromise each of those groups. But putting all that data in, we can put a patient into one of those groups. And what that does for us, so yes, just summarizing that the stratifications have gone from using kind of from 3 risk groups to 6 risk groups, using mostly the blast of genetics and the cytopenias. This is just illustrating that when you go from the earlier classifications on the left to the class of, to the molecular classification on the right, we have been able to, so you can see like the brown, if you follow like the brown low risk group at the top from 1985, it's shrinking because we're able to shift patients to different groups, and that is helping us to be more specific or able to predict the future a little bit better. So, sometimes we say, well, you're in the lower group, and the lowest group is sort of years, but it's hard to be specific about how many years or whatever people, so by trying to make the groups, by trying to specify different groups, we can be a bit more hopefully accurate or specific about actually, more reliable numbers. And so this graph illustrates that a little bit, that on the top one is the revised International Prognostic Scoring System, and on the bottom is the molecular one. and different studies have kind of applied it to their groups. But what you can see is that, so if you take the top bar of each of the groups, the revised, the light blue, very low group. So if you're in that group by the revised IPSS, it says you have, an average of about 8 years survival. But if you apply the molecular version of it, then we've moved some people out of that group and into a slightly higher risk group. So we can predict that some people might be in the area of 10 to 15 years. So that's a little bit helpful if we can say, well, you're in that very low risk group, so you're more like around 10 years. Whereas if you're sort of in the moderate low group, that's closer to maybe 4 or 5 years. And if you're in the higher, the very high risk groups, you're closer to a year. So that's a bit helpful. Does that make some sense?
Do they do this test throughout the process?
So we do it at diagnosis,
Yeah.
and then it's not like So some people ask me like when we diagnose somebody and we say, well, 5 or 6 years, and then when it's 4 years and 9 months, and they say, well, I'm doing okay, but that means I only have like 3 more months to go.
Yeah.
These are averages, and so it's a bit of, and so it's from diagnosis. So to keep doing it isn't that really helpful. It sort of gives us just it's supposed to give us and to give you an idea of how important is this disease right now, and should we, a little bit like the last talk, should we be doing something sooner, or maybe we don't have to do anything too soon and we can wait because we know that nothing much is going to change for a while, right? Yeah.
Excuse me, I'm just wondering if we could get that PowerPoint, or would it be beneficial?
Yeah, I think it's going to be.
Yeah, we'll post them on the website. Yeah.
So treatment. So that's about classifying, and so classifying, like, it seems kind of boring and not very helpful, but it is helpful, I think, in this disease where we are, we have some limited resources or treatments. We have, but just trying to understand what you have, and sometimes why your doctor might be a little less, seem a little less interested in your disease than you are, for different reasons. But it's not because we're not interested, but it's just not. We know it's not. We may not be impacting on life as much, and we may not have much to do or change things right now. Yes.
I think knowing this stuff would help my family as well.
Right.
Yeah, because it's clearer here than I can expect.
Right. Yeah. And so so this is that, like you were saying earlier, some people say watch and wait, or some people refer to as watch and worry, but probably not good terms. But it's a bit of understanding of, well, I have something, and some of it, as much as we try and talk about, well, is it a problem, or is it, it's a problem, but is it a today problem, or is it a tomorrow problem, kind of thing, and to try and explain why the waiting to do something is maybe sometimes better than doing something now, for instance. And we're just going to talk about the treatments and why sometimes waiting to do something is better than doing something. And then, like, some people have had the disease for a while. Sometimes it takes a while to believe us, or to like, it's nothing's going to happen for a while, and then sometimes when it comes time to have a treatment, some people are, well, I'm fine. Like, why do I need a treatment now? So convince people that they're fine until then it becomes more, then we become more excited or seem to be more enthusiastic about the disease, or to inform you about why now it's important, and before it was sort of less, not important, but less a priority, doing something. So the different treatments, so there are a lot of things to do, but not specific anti-myelodysplastic treatments. So, and I think this is the guiding theme of what we do is those two goals, really. One is to improve the blood counts if we can, and the overriding one is the quality of life. Because again, it's not a curable, usually it's not a curable disease. It's a disease that we have to live with, and in the best way possible. So, and then again, sometimes doing something earlier may affect that quality of life. And so it may be, if nothing much is going to change, then it may be better to put that off for a while. So the treatments can be observation or watching, waiting, symptomatic improvement. So again, if we can change the symptoms in any way. So this is in this lower risk. So on the left there, it shows a lower risk group. So we divide although there's six categories in the classification, we basically divide them into, we don't have 6 treatments. We have two main approaches. And so we divide those 6 into lower risk and higher risk groups. And so this is, for the lower risk group is to, again, is to mostly ignore the bone marrow, because we don't have good tools to fix the bone marrow, but try and fix other things, right? Make sure people aren't bleeding, right? Vitamins, if there's anything else causing pressure on the bone marrow with other medications. So anything to allow the bone marrow to function as well as possible, and allow the blood cells to live as long as possible. So, and then if we can't get the numbers up, then certainly transfusions are one way of kind of, I would say, filling up the gas tank. And there's different, so to deal with the anemia, there's transfusions. There are these erythropoietic stimulating agents like EPREX, which people may have heard about. Lenalidomide is a specific kind of, is a medication for a specific type of myelodysplastic syndrome. Immunosuppressive therapy, like we talked about earlier, can be part of the treatment of myelodysplastic syndrome in certain situations. The hypomethylating agents, which we're going to talk about for the higher risk age, can be useful in some patients to, again, try and improve. So we have to, when we think about what are we doing in the disease, it's we should think about what is the goal. We're not fixing the disease, but what is the goal that we're trying to fix with whatever therapy we're trying to do that. So if it's anemia, then if we can improve, we use a tool or something to improve the anemia, then that's our goal to fix. If it's neutropenia, we don't always have to fix that unless someone's having many infections. And for the thrombocytopenia, again, is usually not a problem until the disease is more advanced, but that also can be treated with either transfusions and or other agents. And so the role of transfusions are to improve quality of life, right? So they, and I think we sometimes run into issues in terms of transfusions that there are many studies that have looked at transfusions in other diseases, other scenarios, and it always has been that less transfusions is a good thing, whether it's gastrointestinal bleeding, surgery, ICU. The tendency is to transfuse at a lower hemoglobin level, but there isn't anything that in MDS, where the marrow is not working properly, that tells us whether it is better to transfuse more generously or be more restrictive of the transfusions. But I think the main our main driver about transfusions isn't, and it's not just to fix a number, but it's to help you manage better, right? So we're not trying to transfuse you so that you can train for the Olympics, but certainly to try and manage as well as possible in your usual activities. And so if if there's sort of like if your car has a hole in the gas tank, you need to keep putting more gas in. Otherwise, you run out of gas sooner. We don't want you to run out of gas just because if we have a way to fill up the gas tank. But also some of these things do depend on hospital resources, and different regions are able to do this more or less. So and then there's also the counter, or the big negative to transfusions is the iron overload. So a lot of iron comes in with when you do a transfusion, but that's a longer term problem, after we dealt with the shorter term problem. So erythropoietic stimulating agents are agents like Eprex or darbepoetin that push the bone marrow to make more red cells. And so under certain circumstances, we can measure it's replacing the hormone erythropoietin that is normally made in the body by the kidneys. And the lower that is, the more effective these might be. And if it's too high, they're not likely to work. So they are in most patients, the level is low enough that we can try them, but in some people the level is higher, and we don't use them because they're almost for sure not going to work. They work in about a third. I would say they work in about a third of people, and again, they work for 1 to 2 years if they work. I talked about this. There's this one group of anemia that is associated with a genetic alteration where the 5th chromosome, deletion 5q. So there's the one arm of the 5th chromosome is missing, and in those cases, there's this drug called lenalidomide or an erythropoietic stimulating agent, but lenalidomide is more specific, and it's a pill, and does work in about 2/3 of these patients, but as some people know, not without complications sometimes. So some of these are limited by some of their side effects, but in any event, in patients who have anemia without the deletion 5q, lenalidomide is not usually used, and that's because less than a quarter of people might respond, and the risks can be quite high and maybe not worth the adventure. And then there's a subset of patients who have anemia who have this RARS, or ring refractory anemia, is ring sideroblast, so it's one subtype. So we have some therapies that address certain subtypes of the disease. So luspatercept works again in about 2/3 of patients to fix that anemia. It's not a bone marrow driver. It doesn't push the bone marrow to. It's more like it's in this affecting this transforming growth factor superfamily, which is kind of a inflammatory process. So and so if we calm that down, then the bone marrow may work better. And so they typically have these ring sideroblasts in the bone marrow. So some people may have been told, well, your bone marrow has these disordered cells and these ring sideroblasts. So we didn't pay much attention to them before, but now we pay a lot of attention to them because they open the door to a certain therapy. And often you have this mutation in this gene called SF3B1. Again, immunosuppressive agents are, like we talked about, ATG and cyclosporin, can be used in, for the anemia in low risk MDS, but usually these people have an MDS, a type of MDS where it is just the anemia. They don't have the ring cerebroblast, like on this list. The bone marrow is more hypoplastic than, there's less cells in it, so it looks more like an aplastic anemia or on that side than it does an MDS. And they may have some of these other factors like this gene, HLA-DR50. And then a third of people might respond to hypomethylating agents, and we're going to talk about those in a second in the higher risk group. But they can be used in the lower risk group. This is more like a chemotherapy where it will cause the blood cells initially to be lower, but if it's working, it may allow the bone marrow to work better. Chelation is so anybody who's been transfusion dependent knows that we monitor the iron levels. There's a lot of iron there, so 250 milligrams of iron per bag of blood. And so iron is, normally the body is very protective of the iron that goes into the body. It's hard to get iron out of the body. It's a bit of a long process when the iron goes in. So it's not like too much iron is in the body and then everything's going to go wrong. But there's this process of the iron accumulating and then going into organs and then causing damage in certain organs. We worry particularly about the heart and the liver. And so people who are transfusion dependent over a period of time, and if the iron levels are going up, we like to try and maintain the ferritin anyways below 1,000 if we can. So there's some medications to try and address this by chelating the iron and trying to allow it to come out of the body. It's not for everybody. Unfortunately, one big side effect to it is it can affect the kidneys. And when you're older, most people's kidneys are not functioning always normally. And so it is sometimes the kidneys are a barrier to using it. There's been a lot of studies that have looked at iron. In general, it looks like iron is not a good thing to be, too much iron is not a good thing to be in the body. Question is how long till it has effects and how do we impact on it. There was one main study where they were giving the chelator the ferrosirox to patients versus placebo, and showed that there was a slight improvement in event-free survival, and it didn't translate to overall survival, but event-free survival in patients who are on the drug. Unfortunately, when they were doing the study, it was supposed to show that, or they were trying to show if the drug did or didn't have an impact on the problem. But when they were doing the study, they had already convinced a lot of people that the drug was useful. So a lot of us were already using the drug. So they had a lot of trouble recruiting enough patients to the study. It took a long time. They had to close the study early just because the recruitment was not going well. So that it hampered the final outcomes of the study. And this is a schematic of how to approach sort of the main problems of MDS. So if you have anemia, we look at the erythropoietin level, and if it's lower, then we can use ESAs, and if it's higher, then we have the choice of do they have deletion 5q or not, and the ring sideroblast like we talked about. So the different therapies. If it's thrombocytopenia, those are the options, and if it's all of the cells, we might choose to use immune suppression or transplant, and we're going to hear about that later. It's a bit of a schematic of thinking about how to go through even the few therapies. It makes a very complicated diagram. This is in the higher risk groups. This is the groups where we expect the disease to, or patient to have a survival of 1 to 2 years. And in that case, we're trying to fix the bone marrow. So if your life is going to be quite short, then we're looking to see, can we fix the bone marrow, or can we alter the rate at which the disease will progress? Because eventually the disease progresses to acute leukemia. And it may do that in 2 years, it may do that in 15 years. So in part, it also depends on how young the person is when they're diagnosed. So some people are clearly not clearly, but not expecting to live as long as it takes to switch to transform to acute leukemia, and that's where that becomes not so important. Whereas sometimes if we expect it to happen in a short amount of time within the person's lifetime, then that's where we want to see if we can fix the bone marrow to avoid that from happening, because if that happens, then the disease is a harder disease to treat. And so transplant has been and you're going to hear more about transplant, but transplant has been the one treatment to try and cure the disease. Unfortunately, with a lot of our treatments in hematology, they're either not that effective, but not very toxic, and the ones that are very effective are very toxic. So it makes it very difficult sometimes to assign, who should go with which therapy. And that's why I spend a lot of time in clinic talking about the different therapies, because we need to know patients' goals and assess whether it's the right, what is the right pathway for each person. And then the HMAs, which are the hypomethylating agents, which I've mentioned a little bit, have come on the scene as the way of modifying the disease with less toxicity than a transplant. So these hypomethylating agents. So this was a study, was published back in 2009. The evidence was earlier than that, but this was a study where patient got azacitidine or not, and so this showed that there was those on the blue line who got azacitidine lived longer than those who didn't get azacitidine. So it was the first real treatment that showed that we could prolong the survival of patients with high risk disease, which was exciting because we had nothing before that. And before that, it was, if you had high risk disease, it was just you either could have a transplant, and if you couldn't have a transplant, the only thing we could do was give transfusions and help people to live as well as possible for as long as that would last. So, so there's different numbers that go along with this graph or this study. I think the easiest one to understand is that at 2 years, 50% of people were alive who were on the drug, compared to 25% of people who were not on the drug. So it gives an idea of how impactful the drug has been. Having said that, nobody has like individual, like real world, like, so the studies unfortunately are good, but they also are picking like the super people of each center, right? So a study like this, it's done in 100 to 200 different centers around the world, of which 1 to 3 people will be entered from each center. And we treat a lot more than 3 people each center, right? And so, but to enter the study, you have to be kind of the best of the best. And so when we look at when any center has looked at all their patients that have been treated with this, nobody's had this kind of curve or this kind of outcome. So if you're like, well, how come I'm not doing as well as the study? You're not alone. Most people haven't been able to mimic or show the same prolongation of survival, but it's still prolonged. So than what it would have been. Yeah.
When you get to the high risk like that and you have transfusion, is it possible for the person, like if you're alone, to survive at home alone type of thing? Or is this a stage you get into where you have to go into care? I don't know why I'm asking that. Yeah.
Like, so you're asking, there's two things. So if you're in the higher risk group and transfusion, so I mean,
Or
most
transplant.
people are getting transfusions.
Like
lower-
a transplant.
Oh, transplant.
Yeah.
Well, transplant is, again, so Dr. Masurekar is going to talk about transplant after this. He can be more specific about what a transplant is like, but it is quite, it's not for everybody, and it's quite intensive, and it is has certainly its own risks to just surviving the transplant. So it's not certainly most people who have myelodysplastic syndrome, neoplasm, are not eligible for transplant, because you can see the curve is this older group, and this older group are the ones that are not well enough to, the risks of a transplant are going to be too high. So that's why this is exciting when these hypomethylation agents came on the scene, because we finally had something besides the transplant, so something in between transfusions and a transplant to try and modify the disease. Like I said, so 24 months compared to 15 months as survival. We try and get people through at least 6 cycles to see. It takes time. It's a slow acting treatment. There are some predictors of genetic predictors of better or worse response. And then sometimes we will opt for intensive chemotherapy as opposed to the hypomethylating agents. But they, again, that's intensive, getting closer to a transplant, and not for everybody, but in certain cases, depending on the goal. So I think one thing it's easy to talk about, your hemoglobin level, your neutrophil count, your transfusion. Now that we have different choices of therapies, it's important to talk about, which is more fuzzy, but goals. What is each person's goal, and how are we going to use the tools that we have to meet those goals? And so some people's goals are to be away from the hospital as much as possible. Some people are, do whatever possible to fix this disease, and there's a lot of different shades of in between, which don't just depend on the individual person's goals, but it also depends on the support you have around you. So we were mentioning like living alone, right? So living alone is hard, or it's hard to receive some of these therapies without, if you live alone and you have to drive yourself to the hospital all the time, for instance, because some of them require a lot of visits to the hospital, right? So sometimes we can make the treatment a little more simpler with less visits. That's one kind of scenario, and so there's different shades of how to incorporate some of these treatments. So it's not always so straightforward that, well, I have high risk disease, so I should get this treatment, or I have low risk disease, I should get this treatment. Some of these are influenced again by how successful some of the treatments might be, the supports, the different people's social situations, how far you are from the hospital. So a variety, there's a whole bunch of other factors that come into this, because they're not like just a pill or something. Transplant, well, I won't talk about transplant because that's going to be next. Except what I've said about it, that it's not for everybody. But Ash is going to talk more about that. I will, so ascertain is the exciting next step about, where we have, moved to an oral agent. So this was a phase 3 study. So it's a randomized study looking at the cytidine, which is a cousin of azacitidine or Vidaza that most people are familiar with, and and moving it from a, because as most some people know who get the Vidaza or azacitidine, it's an injection and you have to come to the hospital for it. But so there's always been a push to see, well, can we make the treatment oral? Can we make it easier to take? And so there was, and so those agents are given subcutaneously because they're usually not stable at being taken orally. So there was a way of putting it in a pill with another agent, this drug called cetirizine, which allowed the drug to get through the stomach and into the blood. And so this study basically, there's a lot of words, but mostly it just showed that we could, this was how the study was done, but not so relevant right now. But what was relevant was that we could get enough drug into the blood to mimic what the injections were doing. And so, and the important there was the overall survival. So the median overall survival in this study was 31.7 months, which is longer than the 24 months with Vidaza. Now we're not comparing one, we weren't compared one to the other, but mostly that is significant in that it suggests that we could do the same thing without injections. And so most of the therapy for high-risk MDS now has been shifted from injections to a pill, which is, again, another exciting step. Sort of the same therapy, but now easier to administer. This doesn't really help. It's interesting, but it won't help to understand what we're talking about. And this again is another complicated slide about the decision tree about how to decide on what therapy. And so on the left there with the blue box on top is the lower risk group, and on the right with the red box is the higher risk group. And you can see it talks about, if you are symptomatic or not. So we just observe if you have low neutrophils or platelets or anemia, should we use this agent or that agent? And so it does go through this, these steps. This is the steps we sort of go through, in our head, about a little bit about deciding on what therapy. And then in the higher risk group, we have that choice of a transplant or not, and some of these hypomethylating agents to try and modify the disease temporarily to delay the progression of the disease. And so that's kind of what we think through once we get all the information. I think that's it. I think the only other thing was, well, you may have heard. So yeah, so the only thing I wanted to mention was in terms of related to this oral treatment. So one thing I haven't had here because it hasn't been published yet is that there was a study looking at a combination of this oral medication and another drug called venetoclax. So I don't know if anybody's heard about that, but I thought I'd just quickly, we're waiting for that study to be published. It's a treatment that we use in acute leukemia, which was, so it was hoped to be better than just the hypomethylating agent, but so far the news is that it's not. So sometimes more is not better. And that's another thing, another problem we have in this disease is that there's been a number of, despite the limited number of choices of therapy, there's been a lot of research, there's been a lot of work done on trying to add or to the hypomethylating agents, add other agents that seem to work in related diseases, but haven't but when you put them together, they doesn't seem to add more to the survival nor the quality of life. And so there have been a lot of kind of, we think we're making progress, and then it turns out it's not actually progress. So those studies are all important, and maybe one highlight that because sometimes when we have a new study and we ask people to enroll in the study, and people say, well, I want to get the new drugs. Well, we do the study because we don't know if the new drugs are more effective than what we usually do. And so when we had that initial study way back, when we had to enroll patients on a drug and a placebo, that was even harder to explain to people why you might get the new drug or you might not. Getting the new drug is not always, usually it is, but not always the right side of the treatment. And we're certainly seeing that in a lot of studies in leukemia and in myelodysplasia, where just adding stuff doesn't make it better. It may make it more toxic, and sometimes it's better, but that's why we need to do those studies. So if people ask you to enroll in a study, that's my just one plug about studies, that not being on the fancy new arm is not always better, but it's important to have people on both arms, because we're trying to see which is better, right? If we knew which arm was better, we wouldn't be doing the study. That's my one little plug for studies.
So I'd like to introduce our second speaker, Dr. Ashish Masurekar, who will speak about the role of bone marrow transplant in treating MDS. Dr. Masurekar obtained his medical degree in India in 2000. He then moved to the UK and completed fellowships in medicine and hematology, in addition to a PhD in pediatric acute lymphoblastic leukemia. After moving to Canada, Dr. Masurekar completed his fellowship in transplantation and cellular therapy at the University of Ottawa in 2022. He since joined the transplantation and cellular therapy program as a staff hematologist at the Ottawa Hospital. So welcome, Dr. Masurekar, and I'll turn it over to you.
Thank you very much. Can everybody hear me?
We can, yeah.
Thank you. Thank you for coming on to the talk in presence and also virtually. And I'm sorry I couldn't attend in person. And I thank the organizers and also Dr. Sabloff for making my talk way easier by introducing this complex topic of MDS. As you now know, transplant is just one option, and not for everybody, but as a treatment of last resort. But before patient comes to transplant, there's a lot of complex decision-making process that happens with the leukemia service. So we in a way are more protected than our colleagues who have to deal with a lot more complex medical decision-making process. I'll start by answering Lisa's question because that's not directly, I didn't build that up in my talk. Having a kidney disease, we have a scoring system called a comorbidity index, and patients would score a point if they have kidney disease, but it also depends on what type of kidney disease and the extent of kidney injury. And a lot of our medications that we use after transplant and the chemotherapy we use can affect the kidneys. And so it does become a factor in terms of decision-making process. But I have a slide where I probably will explain that there is no one deciding factor that would be that would determine yes or no. I guess if somebody is dialysis dependent with an end-stage renal disease, that's a different matter. I hope I tried explain Lisa as best I could.
Thank you so much. Yes, thank you.
Okay. So myelodysplasia is like a lot of terms in medicine. It's derived from Greek and Latin words, and it essentially means a marrow-based disorder with an abnormal growth, which causes lots of symptoms and signs, which you now know after Dr. Sabloff's talk, what those symptoms and signs are. I jokingly say to my patients, they call me Ash, it misses H at the start. So I have no conflict of interest to declare, and I thought I pitch this talk more towards trying to preempt your questions and answer and talk more about what you may wish to know rather than giving you too much technical details of MDS. But I'll be happy to dive into that if necessary. The blood system is truly a remarkable system. This is an image from Science magazine more than 10 years ago now, trying to show the flow of blood cells in a vessel with red cells and that starry cell there. I don't know if my cursor works on your screens, but being a platelet and then these small white cells. This is indeed like it's a schematic diagram. But blood flows everywhere and nourishes and nourishes each and every organ or cell of the body. And if we look at the normal blood count that we get on our daily or reports on my chart, we tend to recognize the values of white count between 4 and 11, and or platelets, the sticky cells 150 to 400, or red cells 4 to 5. But then when you look at the values, they range from 4 to 5 billion per liter, and in red cells trillion per liter. So if you then look at the total amount of cells in the body, for example, red cells are about 25 trillion. Just the red cells alone make 25% of all human body cells. So it's a remarkable system. And these cells don't last forever, just like, for example, a heart cell or a brain cell or a muscle cell. They are for life, whereas these cells can last sometimes for few hours to few months to some few years. And so to maintain this cell population, the bone marrow is indeed a remarkable factory. And it does this effortlessly day in and out. We can perhaps appreciate more about heart, and it pumps 6 liters as a pump a minute for every minute of our life. And we know that that's remarkable, but for functioning of hematopoietic system is not as obvious, if I may say so. But on a daily basis, the bone marrow produces trillions of cells to maintain those normal blood counts. And it's all done by this remarkable hematopoietic stem cell at the start. If you show me the marrow biopsy and says, show me where the stem cells are, and I probably wouldn't be able to. They occupy a very tiny fraction of total cells in the bone marrow, yet are responsible for producing these trillions of stem cells. It's literally like a glacier where at the start things appear static and as if nothing's moving, but they feed mighty rivers that feed the civilization. And so again, this is a similar diagram to what was shown previously. On the left is the myeloid lineage, which is today's talk, which produces all these different white cells and red cells. And on the right is the lymphoid cells. And so in this factory, if you see how active this factory is and needs to be for every moment of life, the reproduction of the cell in general is not perfect. If it was perfect, then we would not age. And so the factory is prone to error, in particular a factory which is so active. And so inherently the myelodysplastic syndromes are they are cancers of these stem cells. And they're a group of disorders. They're not just one disorder, but they all have some unique characteristics. The low counts, as we now know, we call it cytopenias, and that can manifest as anemia or being tired, thrombocytopenia, various bleeding and bruising, and neutropenia that would put patients at risk of infections. But when you look under the microscope, the cells look abnormal, which is what we call as dysplasia. And the marrow or the blood would also show blasts, which are these highly abnormal cells, and their percentage determines is also one of the crucial factors that determines the risk category and the predisposition to acute myeloid leukemias, which is an even more aggressive form of MDS. And all these clone or MDS abnormal cells carry genetic changes. And for the purpose of this talk, I'm referring to acquired genetic changes that have been acquired during our lifetime, most of the times from causes that we don't know. Although, as Dr. Sabloff said, smoking, alcohol, previous cancer treatments, exposure to certain benzene chemicals, there are few known factors that predispose MDS, but most of the times we don't really know why it happens. There is also a tiny fraction of MDS that is familial or inherited, but to be honest, that is outside the remits of this talk, but I can talk more about it if need be. But most of the cases, MDS is acquired changes. And that's what is there in my next slide. I have developed some barcodes if people want to scan and get more information. This Cancer Society has a good way of explaining as an initial sort of understanding of MDS and why MDS happens. But most of the times it is unknown. Risk classification, as we now know, there are several versions. So we started off with IPSS, and then that became IPSS-R, and that's become IPSS-M. And as our understanding improves, I'm sure this will continue to evolve. Going by the trajectory of the progress that we have made, we know that whatever we know, there is more to be known. So this is likely to change, but it's essentially based on, as Dr. Sabloff mentioned, low counts, genetics, mutation changes, percentage of blasts, age, and a few other things. And I have more resources there amongst different sites, including the AMAC, which has a very good information on MDS and these classifications and changes. So I'm sorry if this is a busy slide. These are Kaplan-Meier curves, and based on different IPSS-M risk category, which this was a landmark paper in New England Journal of Medicine, and they showed curves of both the treated and also untreated or new patients to kind of describe some natural history. And the first thing I'd like to say is, like, everybody starts off from the top left corner, and then the curve plots the survivors, and there is also something called censoring. That means everybody who is alive at that point. So these curves, when we look at these curves, right from the top being very low risk in green to very high in dark brown, these curves are very good at prognostic classification. So what I mean is they are good at separating groups of patients. But when it comes to individual prediction, that's a very different challenge. And so, for example, when we look at that probability on the y-axis, which says 50%, the median survival is not reached in this very low risk group, which is far better than the very high risk group, I accept. But even in that very low risk group, the curve doesn't remain flat and at 100% over the years. And which is why these curves, even though they show how patients generally behave in a group, we still need clinical judgment for individual planning individuals treatment. But one thing is becoming quite clear that for these very high risk and moderately high risk groups, in general, we need something to alter the natural disease course. And transplant is the only potentially curative option. And I stress on the word potentially because I'll come back to it. I'm not saying that we don't do transplants in the non-high risk groups. If non-high risk group patients who are stuck with severe complications of treatments and requiring frequent blood transfusions with severe impairment of quality of life, we have to factor those in the decision-making process as well. This is a slide, not the same, but a similar survival curve published just last month from Center of International Bone Marrow Transplant Registry Group, looking at the outcomes in matched donor, sibling donor for allogeneic stem cell transplant. Note that the risk group is IPSS-R and not IPSS-M. And this is a complex problem in medicine. As we know more about the disease, our risk classification improves from R to M, but then it takes time for data to mature and in terms of how patients are doing with same treatments or different treatments in a newer classification system. And so the data, as the data matures, it is always going to be lagging behind the mutations and the new classifications that we come up with. But this is by no means a head-to-head comparison, but to give a broad idea where, for example, a very high risk or high risk group, as per the new classification, the 5-year survival is quite poor, if I may use that word. With transplant, that curve has certainly pushed way up along the y-axis, which is an indirect I guess a result of transplant. But the transplant process is not a straightforward process by any means. And I try to sort of view 3 different pillars in the decision-making process, which then obviously unite for a patient. But on one hand, you have this disease risk, which there are different ways of assessing the risk, and then there are unique challenges of then using those risk groups and putting that into patient. We are very good at prognosticating, but not individual disease outcome prediction still remains poor. And that has to be taken into context with individual's health, age, fitness, other comorbidities and conditions. I must say, as we age, the outcomes do get affected by age, but none of the things I've mentioned here is a deal breaker. So the age alone is not the reason to say no. We look at more biological rather than biological age, the actual age, the status of the heart, liver, lung, kidneys, how active the patients are. Also, mental fitness matters in the scoring system. The oldest transplant that we did in Ottawa last year was 77 years age, and I suspect over the years we probably will break that record too. And then the third pillar is the donor. We could have a right disease, the right indication for doing a transplant, and a patient who is otherwise healthy and willing, um, but may not have a perfectly matched donor or a suitable donor. But as we understand transplant, we are now able to do transplants even in settings which may not necessarily be the optimum match sibling donor. And there is some data now on younger unrelated donors, and there is a lot of data that is coming up to say, would unrelated younger donors be better than matched sibling donors? The median age of transplant for MDS patients is in the late 60s. And so the siblings are likely to be along the same age, and there is a lot of research going on to choosing a younger donor. In our setting, we have just published a paper. A majority or vast majority of our patients, we are able to find a donor and do a transplant. But when you have such complex parameters, it is an individual decision. And I must say, I've come across patients who say, "What would you do, doctor?" And that's the hardest question to answer, because everybody's risk appetite is different, everybody's goals are different, and so this is one of the hardest decisions people have to make, in terms of even if it put into context other big decisions that we make in our lifetime. And this doesn't, it's usually my experience that this takes more than one visit and consult to arrive at a decision of whether to do a transplant or not. Sorry, this is a busy slide, but essentially what I'm trying to say here, that this is a lifelong commitment. It's a long journey with lots of steps that started from initial consult. And at the top, what I've tried to do is what we do very well, I must say, or do better as medics on physically or put our biological and clinical hats on and start doing some process, like work up the donors and work up the patients and do scans and do blood tests, put in central lines, plan treatments. But beneath that, there is also a clear recognition that there is a lot more that needs to be addressed and met. Anybody who's going through this process of transplant also undergoes emotional and stress, and also needs a lot of practical help. It is certainly one of the most life-altering events. And so we still not perfect at this in these parts, but we have a team and we have some information booklet. There's a barcode that probably would give you more idea. We have social worker and we have nurses, and multiple visits to try and address these matters. When it comes to treatments, people are well informed about what this involves, and the toughest phase is that 5 weeks of admission, where we do chemotherapy to wipe out the marrow, hit the disease hard and clear space in the bone marrow for the new marrow to come, which is literally an infusion like a blood bag. So there is no surgery, there is no scalpel, but it is in some ways way more complicated than a surgery. Lots of complications that can happen in those 5 weeks, which is the toughest phase. Most places this is done as an inpatient on the ward, with lots of treatments, treating teams and specialists. But here in Ottawa, we have been running an outpatient transplant program for more than 2 decades now, which has been very successful, and we've published in this part, where patients are taken care of on a daily basis and attended to, and they get all the treatments they need. And then they go home if they live within an hour from the hospital or a home arranged accommodation. There are some criteria that need to be met, like a 24/7 caregiver, and they get access to our helpline, and if there's a problem, they come straight onto the ward. But this is another attempt to try and achieve some sort of control, and that patients could have home bed and home food during this tough phase. And surprisingly, it is a favored option if available to most of the patients. And we get asked a lot of questions around, do we need to clean the house, and can do's and don'ts, and generally, as the previous speaker mentioned, if there's no active housework and nobody obviously is sick with cough and cold, then this is equally a safe option to do. But the story doesn't end at discharge, and this is what we mean by lifelong commitment. All patients need to be in Ottawa for at least first 100 days for transplant, even if everything goes well, because at different stages in transplant, we are monitoring for different complications. So as soon as the first phase, the intense phase ends, the new set of challenges start, and mainly acute infections and acute graft versus host disease. On day 0, which is the day you get stem cells, the immune system is weaker than that of a newborn. And it takes months and years for the new system to fully mature. And so this phase still needs a very close monitoring. I would say something about graft versus host disease at a very conceptual level. I have barcodes that tell you more about the short-term complications, and there are some videos on acute graft versus host disease too. But conceptually speaking, allogeneic transplant essentially involves creating a new immune system that is expected to get rid of the last surviving MDS cell. So although we say it is matched, we are talking about matching at only few spots in the billions of spots in DNA. And so we still need a different immune system, a sufficiently new immune system that is going to recognize the cancer cell that the current immune system is not recognizing. And so we call that graft versus leukemia effect. Now, when we aim for a graft versus leukemia effect, the trade-off is also graft versus host disease, where the new immune system attacks the host. And so that's, in a way, two sides of the same coin. And we have no perfect way of achieving a pure graft versus leukemia effect, where we ask the new immune system to go and get rid of the last surviving cancer cell. Because that cancer cell is also, at the end of the day, a cell of the host. And so we're expecting the new immune system to figure that out. There are that phase of the first 100 days is critical, and so are the other ones too. As people move along, as one set of challenges gets solved, the others come in. For example, by 180 days, we start revaccinating the immune the host, and this gives you an indirect estimate of how weak the immune system is. So, for example, we start vaccinating newborn at I guess 4 to 6 weeks of life, but at day 0, the immune system is so weak that we've got to wait for 180 days for immunization. I mean the usual childhood vaccinations. If you fall between the flu season or then we do flu vaccines sooner, but typically it doesn't start till day 180. There could be other diseases like chronic graft versus host disease, to name few. But even if things go smoothly, we know that there is underlying concerns that we are not that great at monitoring and as we are in terms of the classic medical way of assessing. We assess disease and we assess graft versus host disease, but we know that there is underlying lot of issues that that need to be addressed. Things like fatigue, fear of recurrence, impact on sexual health, and also just impact of disruption in general. And as people go more and more beyond the transplant, we still monitor for long-term diseases like heart disease, lung functions, bone disease, other cancers, and endocrine. So in a way, this is a lifelong commitment, and it may not be for everybody. And there are times when if people can have lingering complications of transplant, and I have seen patients who say, "What did you do to me?" And we say, "Well, we cured your MDS." So there are lots of things that need to be taken into consideration, and it's an informed process, and it is patient driven, to be honest. As people go beyond, there is increasing recognition of cancer survivorship. This is for patients who are in Ottawa, around Ottawa, probably know that there is a cancer survivor park not far from the hospital and the Canadian Blood Service. But it is interesting that different people have different expectations and definitions of being a cancer survivor. When we plot Kaplan-Meier curves that we showed you, we say beyond 5 years, and a lot of trials say that an endpoint has been reached. There is clearly a different expectation, and that varies from patient to patient, and it is a very individual journey of what is cancer survivorship. And this picture probably shows the iceberg model of what we can see or what we can measure, but there is a lot more that is impacted. That is not often something we see or can measure, but is equally, or if not more important, in the long term. And so I thought I would maybe, amongst the several goals of survivorship, pick on 3 that I get asked quite often. Maybe there are more, but fatigue is the most common reported symptom, and it is real. Most patients don't return to work for at least a year post-transplant. And a lot of fatigue is because of a lot of things we do, our drugs, and the amount of stress that the human body goes through with transplant. People have also asked me if they age, and we loosely say you age by 10 years, but what we mean by that is that the risk of other heart diseases and lung disease, they all increase as we age, and that clock accelerates by 10 years, which is quite significant in many ways. And some of the treatments that we do for graft versus host disease, for example, involve steroids, and that can also cause significant fatigue. And so we recognize that it's not always addressable, but there are few things that we could aim towards and do. Some practical tips that I list here. Easy said than done, I fully recognize. But nonetheless, they're all fairly important. And there are 2 slides I have that talk more about fatigue. This is the first one. And there are more resources for giving some specific advice on how to cope with fatigue. Sexuality and intimacy, this is another big factor that's not often talked about, or even in trials, not often covered in terms of quality of life. There are certain times when sexual activity is unsafe during active treatment with chemo or infection, or when the counts are low. But treatments like transplant and other chemo treatments also are life-changing in more ways than we can measure. And they change in sexual life can affect a lot of other things. And often people are reluctant to talk about these aspects. And it is important to talk to your doctor and get appropriate help. And again, there are some practical sites that talk more about give you more information. Related to this is also anxiety and depression. It is normal to have good days and bad days, and there are times when the emotions get the better of you, and things like don't worry or take one day at a time don't really help that much, even though we say with the best of intentions. But if you have symptoms like thinking of harming or killing yourself, we should approach the doctors. There are lots of things we can do to help in the best we can. There are certain symptoms that may be attributed to anxiety or panic attack, but may mean something else, or more of a physical illness. But in general, the advice is to connect with your past life, pre-cancer routines. And I rather jokingly say, if it is safe to, if your routine was to smoke and have alcohol, then probably that's not the right thing to do, I guess. But we forget things that we did before, laughing being one of them. I remember a colleague asking me a question to say, it's one quality that we humans have that no other species has, is to laugh. And so we need to cherish that and connect with it, and connect with spirituality or friends and family, and talk to support groups and peers. And in that regards, I really admire today's meeting and the sponsors. This goes a long way. Again, more resources that I thought were good practical sites to get more information. And the fear of recurrence, it is real. One of the main things we talk about when we talk in transplant, in broad sense, is relapse. Most of the time, as we say, the most common indication for doing transplant is IPSS high and very high risk. And whilst transplant is a potential cure, it is not a guaranteed cure, and the relapse risk still remains. And I roughly say the relapse goes down by 50% as a very broad counseling. But it is not zero. And so if the relapse risk is very high at the start, even though it's halved, it is still there. And there's not much we can do, and there's few things we can do. And it's again, don't worry, or one day at a time might mean good, but often we recognize that that more needs to be done, or at least talked about, than just quoting a relapse risk at the start. and few more sites that probably talk best on how to cope with stress associated with relapse. I think this is my last slide. I often get asked about what I can eat, and eating is also a source of pleasure, has been before, and also when people are having chemo, particularly in the initial phase of transplant, the chemo hits the taste buds and also causes a lot of inflammation of the mucosa, mucositis, and so normal diet may not be possible at that time. If patients get graft versus host disease, often they need gut rest and parenteral nutrition and GVHD type diet. But this is more applicable to long-term or even before transplant. We have until recently focused a lot on neutropenic diet and trying to sterilize our diet and have huge restrictions on what we can or can't eat. But recent data is now showing that we can move away from neutropenic diet and focus more on safe food handling. And by that meaning washing our hands with soap and water, keeping hot food hot and cold food cold, um, discarding food that is beyond 3 days or doesn't look right, washing fruits and vegetables under running water before peeling and cutting. And there's now the list of avoid is getting tapered more towards non-pasteurized dairy products and undercooked meats and eggs. But we recognize the nutritional value of other foods when balanced with safe food handling. These are two broad resources. Again, the AMAC has a lot of information about the general transplant process and how to navigate. And lastly, this is a bunch of us. We are not always this happy, but generally a very happy crowd. On this occasion, I must say I cropped the image because we just had a really nice meal in one of our academic talks. But yeah, we are always approachable and willing to answer questions. And I'm with this, I thank today's sponsor and happy to take questions.